Team. I welcome all participants to today's Zoom series of lecture. The topic for today's talk is clinical toxicology. The specific learning outcome for this lecture would be that at the end of this lecture, the students would be able to describe the specimen requirements, the analytical methods, and most common toxidromes in clinical toxicology. I would begin by a brief introduction of the subject, followed by a little detailed description of the specimen requirements, because I believe that this has a major impact on the overall results which are generated by a toxicology laboratory. The analytical methods would not be discussed in much detail because some of them have already been covered in previous Zoom lectures and some are to follow. And in the end, the students will get to learn about certain toxidromes and other intoxications, and what role does a clinical laboratory has to play in the management and monitoring of these toxidromes. Now, Paracelsus, he was a Swiss-German botanist and a physicist, and he once very well said that all substances are poisons. There is none which is not a poison, and the right dose differentiates a poison from a remedy. And I think this is the basic tenet of all toxicology. Just as the Sufi mystic poet Rumi, when once asked by one of his disciples as to what is a poison, had a very beautiful answer, that is, anything which is more than our necessity is poison. It may be power, wealth, hunger, ego, greed, laziness, love, even ambition, hate, or anything, right? So be it clinical toxicology or Sufism, the basic tenet of all toxicology is that the dose alone makes the poison. Coming to the actual topic, toxicology is the study of the adverse effects of chemicals on living organisms and the science of detecting and identifying the presence of drugs and poisons in body fluids and tissues. Now, forensic toxicology is yet another important class of toxicology, and I think it was pertinent over here to mention some salient yet very important differences between clinical and forensic toxicology. The ambit of all clinical toxicology is basically the research, education, prevention, and treatment of diseases that are caused by substances such as drugs, poisons, etc. And hence, it mostly applies to all the toxicological principles for the detection, treatment, and very important, the monitoring of human poisoning, because this is the aspect we don't take care of. In contrast to that, the forensic toxicology deals with the medical-legal aspects of chemical exposure and the toxins. Most importantly, the post-mortem toxicology, human performance toxicology, and the forensic workplace drug testing. Now, in clinical toxicology, most of the initial screening immunoassays, they are sufficient to help the clinician in the detection and monitoring of the patients. So a very high sensitivity is required for the initial screening immunoassays. Whereas in contrast, in forensic toxicology, both screening as well as the confirmation is required to exclude both false positives and false negatives. The actual quantitation and confirmation of drugs is usually not required in clinical toxicology, except for a few cases. And often the time doesn't allow for that. So a very high specificity is usually not required for clinical toxicology. Whereas in forensic toxicology, greater emphasis is laid on specificity and accuracy in identifying the potential toxins. The turnaround time in clinical toxicology is understandably a very inevitable compromise between the speed and the actual of analysis and the actual accuracy and precision of the results. In forensic toxicology, relatively longer turnaround times are acceptable. The analytical techniques in clinical toxicology are mostly immunoassays, which provide rapid but less specific results at a relatively lower cost. Whereas in forensic toxicology, as I've already told, that the initial analysis, it is, in all cases, it is recommended to be confirmed on a second, which is a superior analytical technique, and therefore it is usually costly. Now, coming to question number 1, which of the following indicators is most helpful in deciding whether you have a case of poisoning or not? The options I'm going to show: clinical history, pinpoint pupils, lab analysis of drugs, raised anion gap, signs and symptoms of intoxication.
You should write in the chat.
please start writing down your options in the chat. And for the audience who are sitting over here, please grab your pens and pencils and start writing. I think that is an easier one. This is basically a repetition.
The word poisoning, sir, does it not relate to something forensic instead of the clinical toxicology?
Basically, toxicology, it covers both the clinical as well as the his question was that the word poisoning, should it be reserved just for the forensic cases, or we can use it in clinical as well? So I guess the more medical related term would be toxicology rather than talking about poisoning. But poisoning, it entails both the clinical as well as the forensic aspects. So I guess
actually, yes, Dr. Naisha is very right. When a patient takes poison, whatever the poison is, there are two aspects to it. One is to save his or her life, and second is to determine the manner or who is responsible for that, ascertain the blame, etc. So the saving of life is an acute emergency. And whatever the cause is, we have to save life. Anybody who comes to the emergency with suspected poison, our first preference is to save the life. And in that process, we require a lot of help from a toxicology lab. So that portion of toxicology is called clinical toxicology. When you want to be very quick, you have to be very quick in giving your support to the clinician. That is at least which group of drugs he is dealing with, and what is probably, and if possible, you can pinpoint the exact thing. But you may not be 100% correct in pinpointing the substance, but at least the group should be correct. So that's why what Aisha has told you, it should be very sensitive test. May not be specific, but very sensitive test. That means you should not give negative. You cannot afford false negative. You cannot afford false negative. That means you should not say that there is no poison wherever poison is present. You may be giving a wrong answer. You may give a false positive result, but not a false negative result. One thing is that. Secondly, the turnaround time should be very short. That means you have to be very quick.
And often we have to make a compromise between speed
and speed. Yes. So this is clinical. Whereas when you're talking of the forensic toxicology, now it is a legal matter. It is to be in the court and etc. And in that case, you have to be very correct, but you may take some time to reach a result, to reach a conclusion that what exactly it is. So for forensic toxicology, you require a confirmatory test also, which is time consuming, but very accurate. For example, our chromatographies and GCMS and LCMS, etc. So that is two different branches of toxicology. Clinical toxicology, and she also gave a passing remarks about the option. Option. Also gave a passing remarks on the workplace toxicology. Now, what is workplace toxicology? Which are now called substance of abuse. So those substance of abuse, now it's a very different situation. Now it is not a patient. You are not dealing with any patient. It is not entirely different field. They are absolutely otherwise healthy individuals, but employer wants, is he employing a person who is an addict or not? For example, the job is of driver, the job is of pilots, maybe other jobs also, maybe a doctor, maybe a nurse. So the employer wants that he or she should not employ an adult. So that's why those tests are required in such situation. And thirdly, another aspect he or she is a known addict. And now the case is being referred to you by a psychiatrist. We have a lot of patients, now they are patients referred from psychiatry department for monitoring of these drugs for addicts. Another job for the toxicologist to be done. And then another thing is doping.
Yes.
Doping means now the sports persons in sports issues. In this situation, you require the most accurate test, because sporting events, these sporting events are usually international, and if your test is positive, that will cost the career of the sports person, the loss of the medal, etc. Sir, workplace laboratory comes under forensic toxicology. No, it doesn't come under forensic toxicology. It's a separate field. It's
a separate field, but yet if we have to differentiate between clinical and forensic, it's a non-clinical.
It's a non-clinical thing. It's not non-clinical thing, but it may come sometimes under the court.
Yes.
For example, a driver is driving under the influence of alcohol, and the amount of alcohol present in the blood exceeds the allowed limit, then it becomes a clinical toxicology.
So that's why they have put it under the
so maybe you can it's a separate overlap.
Because sometimes मैं आगे lecture में कहूँगी कि even the clinical cases, they have a forensic potential to them.
Yes.
Even clinical toxicology can turn into
that is.
So there's always some areas and
same patient. First, it's a clinical toxicology question, and then it may become a forensic toxicology question. Okay, the workplace testing may be initially just screening, and it may become a forensic when it involves some accident, involves some crime. Okay, then there is another field. The doping, I told you, doping is a very important part, and the same instruments which we are discussing on Fridays, same techniques, chromatography and MS, they are employed for doping. And I told you the most accurate technique, which is IDMS, that is usually employed for the doping test, and we do not have a doping facility. Then another field, which is called forensic chemistry. Now, forensic chemists are very different people. For example, a custom people, they see some drug on and they want to know whether this powder is some banned item or not. Now, who will do that? Usually, that has to be done by the forensic chemists who deal with the substances. But if they are not present, then a toxicologist has to do it. But this is exactly not in our ambit, I tell you. We should avoid doing those things, because our systems are tuned with the biological specimen. So why we are this part of your curriculum? Why we are discussing it? Why we want you to know this? Because if you are even in a very small lab, you will come across a situation where you have to deal with toxicology. You will have to, if nothing else, you will be involved in collection of samples, and you should know how to collect samples. Alcohol, you may be involved in doing alcohol testing. So, and if you may be employed in a very hi-fi lab, and you are involved in doing these tests too. So that's why it's part of. And I tell you, अब मैं एक टिप एग्जामिनेशन टिप बताने जा रहा हूँ आपको सबको, एमफिल और एफसीपीएस वालों को, ये गौर से सुने आप लोग कि ये आपका जो टेबुलर स्पेसिफिकेशन है, जो कि आपके पास एक्सेस नहीं होती उसकी. टेबुलर स्पेसिफिकेशन इज नॉट एक्सेसिबल टू द स्टूडेंट्स, दे आर एक्सेसिबल ओनली टू द एग्जामिनर्स. उसमें बाकायदा ये इसका सेपरेट पोर्शन है, टीडीएम टॉक्सिकोलॉजी. इसमें से जरूर क्वेश्चन आता है, ये मैं आपको बता दूं. इसमें से या दोनों में आएगा या एक में आएगा, क्वेश्चन इस एरिया में जरूर होता है. तो डोंट लीव इट फॉर द चॉइस और समथिंग लाइक दैट. ठीक है, ये खामखा के फिचिंग मार्क्स होते हैं और खामखा के लूजिंग मार्क्स होते हैं. एंड लोग छोड़ देते हैं, वो क्वेश्चन आ जाते हैं, जरूर आता है, मैं बता रहा हूँ जरूर आएगा क्वेश्चन, बिकॉज इट इज पार्ट ऑफ द, मैं आपको ये नहीं बता रहा कि उसकी परसेंटेज कितनी है, कितना आएगा, वो कॉन्फिडेंशियल है, लेकिन ये है जरूर आपके पार्ट, ठीक है। तो इसको बहुत गौर से सुना करें और पढ़ा भी करें। थैंक यू वेरी मच, सॉरी मैम मैंने आपका टाइम लिया
because it's quite long.
प्लीज
The correct answer is C. So all of the options, you know, they as a group are important in helping identify a case of poisoning. Yet the most important still remains the actual laboratory analysis of drugs. The choice of toxicology specimen is another important aspect. In our lab, blood and urine are the most commonly analyzed specimens, followed by gastric lavage, right? But in blood and urine, the concentrations of drugs, they constantly change depending upon the relationships between the time of dosing and the time of sample collection. So the rule of thumb is that try to get the sample as soon as possible when you suspect a case of poisoning. And for example, obviously we have another important branch that is postmortem or autopsy samples. It's basically not the ambit of this lecture today. In addition to blood and urine, we can receive various tissues for postmortem toxicology, but obviously a tiered or stepwise approach is recommended for such cases. Now, what are the advantages of blood as a toxicology specimen? Blood shows the best correlation to the effects of on an individual poisoning, and it has the advantages of ease of availability, ease of interpretations, as we have vast research available in this field, and hence, this is a very important point which I am going to tell. Quantitative analysis has only got a value when it is analyzing blood and not other body fluids, right? It is easy to safeguard the integrity of the blood specimens, and drugs which may not be excreted in urine are often detectable in the parent form in the blood. Whereas, as far as urine is concerned, it is non-invasive, obtained easily. We have a sufficient sample volume. Drugs are mostly present in higher concentrations, and one of the other two important advantages of urine over blood is that it has a longer window of detection. And the most important thing, which I have highlighted as well, that it is a choice of on-site technologies for rapid results. Because most of the rapid technology results, they are available in urine as a matrix rather than blood. And also, just like blood, we have extensive clinical studies which inform and guide us about the interpretation of results. However, as far as disadvantages are concerned, it has a not as good, correlation to drug effects as compared to blood. And we have ease of filtration and dilution as well. The parent drug may not be excreted as all, and this is a very important aspect, because if you are especially interested in finding the parent drug, for example, in the case of benzodiazepines, you may not find the parent drug at all. So you might have to refer to some other metrics for quantitation of that drug, like blood. And then we have collection considerations. For example, some might, especially in forensic, they consider invasion of privacy. We need to ensure same gender collection. Sometimes donor may not be able to provide specimen at all. Now, my question number 2 is, these are the options. These samples were received in the laboratory for drugs of abuse analysis and checked for sample integrity. Now, which of these samples is most likely to be rejected? Please start writing down answers in chat. And if you permit me, I'll start, asking the audience from over here. Dr. Afshan, आपका क्या ख्याल? Okay, why is that so? Yes. Okay. So what she's trying to say is that we are having different results of specific gravity. What? Yes, C. Somebody just wrote C. Why C? You have to, for every answer you have to give have an explanation for that. The correct answer in this case is, as very well said by Afshan, B. Now let's see how. Now, checking integrity of urine samples, it should be checked. It is, more strictly a criteria for forensic toxicology, but it is always a good lab practice to, check the integrity of the urine before embarking upon the actual testing. So we have basically three criteria for checking the integrity of urine, that is pH, specific gravity, and the urine creatinine. And the cutoffs and the values I have already flashed on the slides. Specimen is reported in related with discrepant creatinine and specific gravity result. And obviously, ये mics आप लोग अपने please off कर दीजिए because so if there's any alteration in the sample, that is another one. The next samples are the gastric contents. They include vomit, gastric aspirate, or stomach washout. And the more important thing is that we might find the actual evidence in the gastric fluid, undegraded tablets and capsules. However, just as I have already told that just like urine, the quantitative analysis serves no purpose in body fluids other than blood. For example, for reflecting the amount of poison that is being absorbed. Now, here is also a good toxicology specimen, but as I have highlighted, it has no value in acute poisoning. It is useful in chronic poisoning, for example, by heavy metals, or when we are interested in performing drugs of abuse, for example, opioids and cannabis. Since the chemicals which are present in the blood, they might be transferred to the hair and stored in the hair follicle. Hence, hair testing provides a rough timeline chronology of drug intake events. And there's another important thing that we might expect, unlike other matrices, we might expect ethnic variations in, and why is that so? Can anybody from the audience sitting over here tell me? Why do we expect ethnic variations from the hair metrics?
Its protein content is different.
Which protein content? Yes, this is basically because the dark colored hair, they tend to concentrate the hair more due to possible binding to melanin. So we need to establish different ethnic reference intervals in hair especially. One of the major advantages of hair is that it is easy to collect, has a larger surveillance window. That is basically why I prefer it for drugs of abuse analysis in some cases. It is a robust and stable matrix, and it does not require refrigeration at all. All we need is to place a tuft of hair at room temperature even. The question number 3, I think some of you are going to find it a little hard. Anyways. Analysis of delta 11 not 9 THC or carboxy THC specifically recommended in hair analysis of cannabinoid suspects because the options are shown over here. Please start writing your answers. Dr. Amreen, आपका क्या plan है?
ऑप्शन नहीं है
कोई तुक्का लगा. Okay. Why?
आप लोग भी आंसर लिखो.
Okay. So the other metabolite, that is delta 9 THC, is also ingested. So why not delta THC? I have specifically delta 9 THC. Dr. Zuba, क्या है correct option? C. Why C? Somebody from SUIG has come up with an option of C. So why C? Just बोलिए. Okay. I think I might flash the correct option. The correct option is D, right? To differentiate active consumption from passive cannabis exposure. And let's now see why. You might have to, concentrate closely on that. This 11-ol delta 9 tetrahydrocannabinol 9 carboxylic acid, or abbreviated as THC carboxy. It is actually the primary inactive metabolite. Yet, we are interested in finding this specific metabolite for embarking upon differentiation between an active consumption and a passive cannabis exposure. Why is that? There are basically two reasons for that. It is the in vivo metabolite of THC, right? So you do not expect it to be present in smoke or dust. So if you have to differentiate whether the patient has an active consumption or a passive cannabis exposure, experts recommend analysis of this particular analyte alongside delta 9, which is the primary psychoactive metabolite in here, right? And the second important thing is that it has a long half-life as compared to the other metabolite. However, the detection is very much analytical challenging due to the presence of smaller quantities. And also when its absorption is it's slower as compared to the other analyte. And when we are analyzing it on the liquid chromatography mass spectrometry, in the main MRM, that is multiple reaction monitoring mode tracings, there are certain intense matrix-induced peaks, which are present around the expected retention time of this analyte. And in here, we know it is a complex mixture of certain substances. So most of the substances, especially the fatty acids, they are known to be of similar molecular weight and even size to this particular analyte. And they might interfere around the suspected time of analysis, making the yield difficult, right? So you really need to have very low detection limits for this analyte. The next question is, a urine sample from a suspected case of accidental antifreeze ingestion has been received for toxicology, but the laboratory does not have assays for a commonly present ingredient, that is ethylene glycol. Which simple test you may like to carry out on the urine sample that may support your diagnosis? I don't have any options for that, but let me give you a hint. It is a non-biochemical test in urine. Well, I was expecting at least
you need a microscope for this.
Okay, yes.
Good.
Very good. Very good.
This is a superb answer.
I think that's a superb answer from Sumbal. That is urine microscopy to see calcium oxalate crystals. I'll explain you later on why is that so. The second part of this question is, I think this should be easier. Name 2 biochemical tests in blood that may support your diagnosis in this case. I'm not using the word confirming the diagnosis, that might support your diagnosis in this case. Biochemical tests in blood. Yes, or an ion gap, right? Or yes. In fact,
there should be a smaller gap.
A smaller gap, that is right. Even an ion gap is correct answer, because ethylene glycol, it contributes more to the anion gap as compared to other alcohols. So probably I've written an anion gap as the option. Arterial blood gases. So why, Dr. Green, why do we need to have arterial? What are you expecting in these ABGs? What derangement are you expecting in arterial blood gases of such a patient? Yes. And why metabolic acidosis? No, why a metabolic acidosis? What actually contributes to the metabolic acidosis? Actually, the interesting thing about all these alcohol intoxications is that as the metabolism, now this is a very important point, as the metabolism of alcohol proceeds, we start getting their metabolites, in this case glycolic acid and oxalic acid, and it is actually these metabolites which contribute to the high anion gap and the metabolic acidosis. So you might receive a case of alcohol intoxication in which there is a little time has lapsed between the actual ingestion and the time of taking the specimen, and the patient might not have time to develop the anion gap or the osmolar. So this point should be kept in mind, right? And likewise, there might be a reason when the metabolites have been formed, and there are raised osmolar gaps and anion gaps, but the alcohol concentration in the blood, it starts decreasing actually. So you must keep in mind both these situations. Now, another important thing, this for ethylene that's what I have mentioned for ethylene glycol poisoning as well. And for the other, I think I should not tell you right now because it's next question. Okay, antifreeze injection जो है, ठीक है ना? What is antifreeze? It is basically used as a solvent in radiator coolants, etc. Methanol is also a component of these antifreeze solvents. So can somebody tell me one single biochemical test other than the actual monitoring of ethanol and methanol levels, which might differentiate between methanol and ethanol poisoning? And have I made no? Osmolar gap is expected to be raised in both, right? So my question was, what is another biochemical test? Antifreeze might contain methanol and ethanol as well. So one of the tests is if you directly measure the quantities in, but headspace chromatography might not be available in any setup. So give me one biochemical test which would, help you in supporting your diagnosis either towards ethylene glycol or methanol poisoning. उसका हिंट इसी में है जो मैंने पीछे जो आंसर है ना उसका हिंट इसी में serum calcium levels, because you expect a normocalcemia in methanol poisoning where you expect a hypocalcemia in, because these calcium oxalate crystals are carried away by the kidney and excreted in the urine. Okay. Ethylene glycol, when ingested, is broken down by the body to glycolic. This is basically a repetition. And oxalate is excreted by the kidneys, and it readily precipitates with calcium to form dihydrate and the more stable monohydrate crystals, which you should see in urine. Now, the laboratory has a great role, clinical toxicology laboratory has a great role to play in the actual detection of the poisoning. Yet, as chemical pathologists, we must not forget that there are other biochemical abnormalities which I've just talked about in poisoning as well. I would not go into much detail of each and every one. You can get the slides of these later on. However, some of the important aspects which you should not miss are the metabolic acidosis. A high anion gap metabolic acidosis is expected in various ethylene glycol poisonings, and additionally salicylate. It is also notorious for causing metabolic acidosis, both in children as well as adults. But can anyone tell me, in adults there is yet another mixed disorder? What could that be? It's also flashed over here in the slides. Yes, because in adults it might cause stimulation of the respiratory center, leading to wash away of carbon dioxide and hence the respiratory alkalosis. Likewise, these increased anion gaps and osmolar gaps are seen in various alcohol poisonings. Electrolyte disturbances are pretty common in certain poisoning, and it's flashed on the slides. Hypocalcemia, especially seen in ethylene glycol and oxalate poisoning, which binds calcium. And then, very importantly, hypoglycemia. We must not forget taking glucose levels in such cases, especially in children, because they are more prone to hypoglycemia. And certain poisons like ethanol poisoning, inadvertent accidental ingestion, they may place themselves at high risk of hypoglycemia as compared to adults. Paracetamol poisoning. Paracetamol poisoning, it is known to cause both raise in transaminases as well as hypoglycemia, especially those who have pre-existing liver pathology or who in cases of chronic liver diseases, etc. Now, a very important aspect is sample collection and preservation. Aseptic techniques should be employed for all collection, but in alcohol, it is very important to remember that we must not use the swab which contains alcohol. It is mostly isopropanol or isopropyl alcohol. We can use alternate swabs like benzyl colonium chloride, etc. 5 to 10 ml of blood collected in potassium EDTA tubes is an ideal sample, because we prefer whole blood testing in these toxicology cases. Gel tubes should be avoided because they can absorb some drugs, and one of the very important drugs which get absorbed by these gels are the tricyclic antidepressants. Labeling and the samples is very important. Sealing and chain of custody pro forma has a more stringent requirement of forensic toxicology. Yet it is a good lab practice to seal all these clinical toxicology specimens, because later on they might turn into a forensic toxicology scenario. Now, anticoagulated whole blood is essential if the poison is associated mainly with the red cells. And four things, that is carbon monoxide, cyanide, lead, and mercury. They have to be taken in any case in the whole blood. So we prefer whole blood over the serum. Now, sodium fluoride, it is an important anticoagulant and a preservative, especially for autopsy or postmortem cases, because it prevents blood from postmortem changes like bacterial production of alcohol, and helps minimize fermentation. And it not only helps minimize fermentation, but it also protects other labile drugs like cocaine, nitrazepam, and clonazepam from degradation. The estimated detection periods for selected drugs, you don't need to memorize all of them. You just need to remember a simple thing, that the estimated detection periods for drugs in blood, they are usually on the order of hours as compared to urine, whereby they are in the order of days. And especially a very peculiar thing about this cannabis poisoning. In chronic cannabis users, the urine detection times might increase up to 28 days. And this is very peculiar for the cannabis poisoning. So we have to really keep this in mind. Now, discussing all the analytical methods in detail is beyond the ambit of this lecture. However, I'll just enumerate these analytical methodologies, and we can discuss it in detail in other Zoom lectures. They start from the color tests and chemical spot tests and immunoassays up to highly sophisticated like gas chromatography, HPLC, and liquid chromatography, mass spectrometry, and atomic absorption spectrometry. Dr. Uzuba, atomic absorption spectrometry कौन सी poisoning के लिए use होगी? तो एक general लफ्ज आप उसके लिए क्या use करेंगे? In trace metals poisoning, right? Atomic absorptions के लिए रखेंगे. अच्छा, इसमें मैंने सिर्फ कलर टेस्ट और केमिकल स्पॉट टेस्ट को हाईलाइट किया है. द पिक्चर यू आर शोइंग, क्या लिखा है? आई कांट रीड इट ओवर. लेड, yes. Okay, this the picture I have seen over here, this was actual case of organophosphate poisoning, and we did a spot test in gastric lavage. The tube which is being shown on the left side, it turned out to be positive for that test, and it yielded a bright yellow color, right? And the right one is a negative control. Some of the tests are the Trinder's test, formaldehyde test. You can find the details in the books. However, an important thing to remember over here is that the colors exhibited, they vary, and the assessment is very subjective, right? So they are reserved in only a selected cases for the initial screening. And importantly, the complexes which are formed, they are unstable, so that the color changes or fades away with time. So you really have to interpret these within time. And it's sometimes very subjective. I'll also not go into the details of immunoassays. Mostly competitive immunoassays are normally used, including radioimmunoassay, ELISA, and fluorescence polarization immunoassay. Then we have chemiluminescence immunoassay-based instruments as well. The immunoassays are rapid and convenient methods to screen large number of samples in a variety of matrices. Now, this is a very important question. Immunoassays required for TDM, that is therapeutic drug monitoring, and toxicology of drug screening, generally are based on similar principles and considerations, but usually differ in which of the following aspects. The options, they are very close options, let me tell you. So please start writing in your answers in the chat.
And you write
it's a slightly difficult question. The options are actually very close. So 30 seconds extra मिल सकता है. A, enzyme labels used by.
सब लोग डिसाइड करके ना लिखें ताकि आपको डिसाइड करना है. कि क्या है?
ऐसे मैं इस नोट करने से लिख तो रहे नहीं,
हाँ, नहीं लिखो लिखो,
लिखे जी,
अपना आंसर कमिट करो ना।
कमिट करें, be it for any
हाँ.
reason, but just commit your answers. Enzyme. I think most of us are, adamant upon.
चलें इनसे पूछे जी, ये
बताएं जी, नहीं इसकी बारी है, वो लास्ट डॉक्टर ने था, आपके ख्याल से क्या आंसर है? मैं ज्यादा से पूछ इसलिए
नहीं, ये तो बहुत जूनियर है, सीनियर ये डॉक्टर अपना
पीछे भी एक्चुअली कुछ बैठे नहीं,
हम शायद मालूम नहीं है प्लान किया ना।
इंक्यूबेशन टाइम, so why is that so? You need to have
आपने बताया ना कि बहुत अगर ब्लड में तो टाइम बहुत
टर्नअराउंड टाइम कम करें। चलें,
not exactly, because the turnaround time might be important in TDM as well. For example, मेरे पास अगर एक tacrolimus का केस आया या even for methotrexate, वहाँ भी हमें बहुत जल्दी चाहिए, not exactly. और जी वो specificity, okay, why is that so? Why is that so?
सुम्बल को पूछो
जी, सुम्बल,
ये मुश्किल सवाल है ना,
थोड़ा सा मुश्किल सवाल है बनाने में,
कोई आंसर देना है।
Could be B.
Yes, it is B, but why? Okay, मेरे ख्याल से अगली स्लाइड पे इसका आंसर मैं बता दें जी, why is it B?
The cross reactivity is important.
Somewhat near.
For specifically for TDM, I would say.
The cross reactivity
of the antibodies. यानी कि हम panel में regarding it's a panel, so we need to know the antibodies which are we using. We need to know the extent of the cross reactivity of एक drug को पकड़िए या
she's probably saying कि जो TDM है उसमें हम वो panel of drugs लगा रहे होते हैं, so we don't need to have the cross reactivity for that.
We need to have it. In some cases we need to have that cross reactivity.
What do you mean by panel of drugs?
Means कि मैम हमारे पास एक panel.
Do we have a panel of drugs in TDM or toxicology?
Toxicology.
Okay.
You mean they're less specific for toxicology, more specific for TDM?
For TDM.
More specific, yes. The answer is very correct. We need to have. वो तो बिगिनर ने भी तो बहुत जबरदस्त तरीके से बता चुके होंगे. Okay. Now this you need to pay close attention to this. In quantification, the immunoassays of TDM and toxicology, they differ in basically two important aspects, right? One is the quantification. The TDM or the therapeutic drug monitoring, it requires fully quantified results. Whereas in toxicology and more so in clinical toxicology, we are not interested in quantitative results. So they are usually qualitative, except for a very few scenarios, which I'm going to highlight in the next slides. And the very important thing, which was the question in the previous slide, is the selection of antibodies. Now, in therapeutic drug monitoring, you have to monitor a patient for a certain drug. For example, methotrexate or tacrolimus. So we need to exactly, identify that specific drug. So that requires a very high specificity for antibodies that is reactive only with that single chemical entity. The one which is reacting with tacrolimus should not cross-react with methotrexate, right? Whereas that is not the case in toxicology, whereby antibodies may be designed to be broadly cross-reactive with a whole group. And you can confirm them later on. You can confirm the specific drug later on a superior technology, right? So I think I've made myself clear. Question number 6 is the analytical technique which is used in a toxicology. That is an easy one. Toxicology laboratory to separate the components of a mixture of volatile substances is, the options are flashed over here. I think the answer is headspace chromatography. ये तो easy था मेरे ख्याल से. Answer C. The answer is C. That is C. Yes, headspace chromatography. Actually, so मुझे यहाँ से नजर पे नहीं आ रहा.
C चल रहा.
Good. The answer is C. Now, headspace chromatography, it is a state-of-the-art instrument for the detection of volatile mixtures. And volatile mixtures are extracted from a heaviest sample matrix and injected into the gas chromatograph for analysis. Now, the basis of all sample preparation for headspace chromatography is that you need to have the maximum. इसको जरा गौर से सुनिए, क्योंकि इसकी बेस पे मैंने अभी एक क्वेश्चन पूछा. You need to have the maximum value in the headspace and less value in the sample, so that you can quantify it easily. right? So there is an entity that is known as the partition coefficient or the ratio. It is basically a thermodynamic property that defines the relative concentration of a compound in the sample as compared to the headspace. So my question is, if you are interested in, if analyzing ethanol, for example, because basically we analyze mostly alcohols on the sample, do you need to have a higher partition coefficient or a lesser partition coefficient? It is denoted as K, right? So from now onward, I would refer it as K, capital K. Do you need to have a higher K value or a lower K value for analysis, effective analysis of ethanol? Or I think that's low. The ratio is basically the relative concentration of the analyte of interest in the sample as compared to the headspace. Dr. Simi ने बिल्कुल ठीक बताया है, we need to have a lower partition coefficient. Why? Because if it's simply maths का सम है ना, it's the जब भी numerator आपको ज़्यादा चाहिए होगा तो you need to increase the value, ठीक है? So the numerator over here is the sample volume. We don't need to have the volatile in the sample actually. We need to have in the headspace, right? So we need to have a low. अच्छा, एक और बड़ा important सवाल है. इसमें एक क्या चीज़ है? Name one single entity in headspace chromatography which is used to lower this K value. Toxicology में जिन लोगों ने काम किया है, this is a very important parameter which we select before embarking upon the actual diagnosis. One single parameter which is used in headspace chromatography. ये बाकी लोग भी chat में अपना आंसर लिख सकते हैं. Name one single. I think थोड़ा सा मुश्किल है. This is the temperature actually, right? And temperature किस चीज़ का? Excellent. ये किसने लिखा है? जबरदस्त. That was a superb answer. This is the temperature actually, right? That किस चीज़ का temperature? Temperature of that vial जिसके अंदर हमने we call it as GC vial जिसके अंदर हमने वो sample रखा हुआ होता है. And for ethanol we set the temperature as high as 85 degrees centigrade. So that was a really excellent answer by.
Optimum temperature इतना हो कि वो maximum उसका vaporization भी हो जाए, लेकिन destruction भी ना हो, वरना तो आप 100
destruction होगी तो हाँ
destroy कर देंगे.
Okay, I think that is the last about toxidromes. It's a constellation of signs and symptoms that consistently result from particular toxins. A very important thing is, though the signs and symptoms are common, yet they might not be overt, rather subtle. So, and there might be intra and inter-individual variations in presentations to similar toxins. Now, the important mechanisms for these toxidromes are the intentional overdose, as we get in cases of suicide, and inadvertent injections. ये inadvertent injections किस population में होती हैं? बच्चों में, right? So these are the two. But having said that, we should not forget two important causes. That is the medical non-compliance, and the most important is geriatric polypharmacy. Now, what is that? What do we understand by geriatric? In old age, the clinicians or the physicians, they prescribe a number of medicines, right? And in old age, we have the people might have been having compromised renal functions or liver functions, right? So this polypharmacy that has to be carefully monitored in these patients, because these are the group of patients which are prone to developing these toxidromes due to this polypharmacy, rather than the inadvertent injections or the intentional overdose, right? Okay, the usual suspects are sympathomimetics, anticholinergics, cholinergics, opiates, and sedative hypnotics. Due to time constraints, I'll just discuss some of the important aspects, right? Can somebody read out the question for me, Dr. Amreen? A question please, for the audience.
35-year-old male has been brought to the accident and emergency of the hospital with drowsiness and irritability. He has urinary retention, dry mouth. On examination, he is dry, has tachycardia and flushed skin. His pupils are dilated and bowel sounds are mildly diminished. The lateral duty is some drug intoxication. What is
So the options are flashed. Okay, I think that was an easy one. D. Okay, yes. The answer is anticholinergic poisoning or D. ठीक था जी. Anticholinergic poisoning, as the name indicates, it causes inhibition of the cholinergic neurotransmission at muscarinic receptors. तो ये receptors किस किस्म के होते हैं? From our understanding of physiology, nicotinic receptors, which are located in the nerve motor junctions and the skeletal muscles, and the muscarinic receptors, which are located mostly in the internal organs, like the gastrointestinal, genitourinary, right? So basically, antagonism due to nicotinic inhibition is usually not a part of this anticholinergic poisoning. It is basically the muscarinic receptors which are affected. And various classes of medications have anticholinergic properties like antihistamines, tricyclic antidepressants, atropines, and cold preparations. And what they do is that they act by occupying these muscarinic receptors at the parasympathetic nerve endings, इसीलिए इनको parasympatholitics भी कहते हैं, ठीक है? Thereby leaving only few receptor sites free to respond to acetylcholine. Acetylcholine is there, but there are few receptor sites which are left free to respond to acetylcholine, and hence the symptoms. So what symptoms do we expect? Symptoms come from the central and the peripheral antagonism of muscarinic receptors. Now, the effects of the central antagonism of muscarinic receptors, they range from short-term memory loss up to hallucinations and psychosis. And the important peripheral effects include dilated pupils, dryness of mucous membranes, urinary retention, and decreased bowel movements, and hence the symptoms which were shown in the previous slide. Question number 8 is I think this is also pretty easy one. A 3-year-old child has presented in an emergency with very high grade fever, is hyperventilating, and has a fit on reaching hospital. The clinician is suspecting salicylate poisoning. Which investigation is confirmatory? I repeat, which investigation is confirmatory, not supportive. I'm not talking about supportive investigation. These are the which investigation is confirmatory? Dr. Mubin is saying
question change करते हैं आप
वो ये थोड़ा सा change
retract हो जाता है.
तो मैंने इसीलिए कहा था इसको गौर से पढ़ें. which investigation, वो मैंने असर आगे भी इसी तरह का एक डिट्रैक्टर रखा हुआ कि वो which investigation. The answer is B, right? Because we are interested in confirming the diagnosis.
इसलिए तो supportive होगा.
किसी ने ferric chloride तो नहीं लिखा, because मुझे ये खतरा था कि ferric chloride ना लोग लिखते, because ferric chloride, no wonder, it is a very important, initiant, and we still do that. But इसके साथ मसला क्या है? I have shown कि though it is a simple rapid test for exclusion of salicylate poisoning, but its specificity is very low. At concentration more and equal than 30 milligrams per deciliter. तो ये वही बात हो रही थी ना कि for detection of a specific group, initial screening के लिए अगर मैं use करूँगी तो it might be good. लेकिन अगर I have to use it specifically for salicylates, it has to be very specific. So इसमें हम use, and the interpretation is also very subjective. We sometimes get false positive results by phenothiazines, और इवन बच्चों में ये जो हाइपरबिलिरुबिनिया के केसेस होते हैं, इस केस भी सेप्सिस वगैरह में एक्सटेंसिव बर्न्स के पेशेंट्स इनमें फॉल्स पॉजिटिव रिजल्ट आता है. However, in a patient with hyperpyrexia, जिसकी normal ABGs हैं, and there is absence of metabolic acidosis, it essentially rules out salicylate poisoning. मैंने आपको बताया था कि high 9 gap metabolic acidosis भी ये cause करती है. What happens in salicylate poisoning is that there is decoupling of the oxidative phosphorylation systems, and all ATP dependent metabolisms are affected, hence the hyperpyrexia, right? और इसकी एक और बड़ी important चीज़ है कि this is a scenario where we might do the quantitative analysis, and since it is a slow and continuous absorption of the drug, so it may necessitate repeat plasma salicylate estimation. Another very important cause of poisoning is paracetamol. It is widely available as an over-the-counter medicine, and usually inadvertent or intentionally overtake होता है इसका. Paracetamol toxicity, it depletes the liver glutathione stores, resulting in toxic accumulation. ये जो है जी N-acetylene paraquinonamine है. This is basically a metabolite of paracetamol, and normally it is degraded by glutathione. लेकिन जब paracetamol toxicity होती है तो the glutathione reserves are depleted, and hence resulting in toxic accumulation of SNAP. और ये करता क्या है? It binds to proteins and causes centrilobular necrosis. जो पैरास्टामोल पॉइजनिंग की एक स्पेसिफिक चीज है ना, इन कंट्रास्ट टू अदर पॉइजनिंग, वो है इसकी स्पेसिफिक फेजेस. सी, सो लर्निंग द फेजेस इज वेरी इंपॉर्टेंट. वाई, वो आगे बताऊंगी. क्योंकि फेज 1 जो है, इट माइट इवन कोई नो, दे माइट बी नो सिम्टम्स एट ऑल. ठीक है, वहां से लेके नोजिया वॉमिटिंग से स्टार्ट होता है. After 24 hours, the patient starts developing right upper quadrant pain, followed by elevated liver enzymes and prolonged PT. In phase 3, he might develop full-blown hepatic necrosis and encephalopathy. And in phase 4, which lasts from 4 days to 2 weeks, there is usually complete resolution of hepatic dysfunction if damage is not irreversible, right? And it depends upon the age and the pre-existing liver status of the patient as well. Now, this slide is very important because the lab has a great role to play in paracetamol testing. And this is one single scenario where we need to have the quantitative analysis. So, पहली तो ये है कि it helps in early diagnosis. ठीक? The sample should ideally not, मैंने ideally का लफ्ज इसीलिए उसमें italics में लिखा. Ideally, that's what the text says, that it is not to be taken until 4 hours after ingestion, since before then the processes of absorption and distributions are incomplete. But is it practically feasible? एक patient तो जी emergency में आया, आप कहेंगे कि 4 घंटे बाद बुलाएं, तो physician would say कि जी डॉक्टर साहब, अब आपको क्या पता? So the rule of thumb is that if we don't know the exact time of ingestion, we should measure a second paracetamol level about 4 hours after the first. First, आप किसी टाइम भी ले लें, आपने 4 घंटे का वेट नहीं करना कि जी किताब में हमने पढ़ा था कि 4, आप ले लें फौरन and then get it repeated after 4 hours. So फिर आप उसको एक नोमोग्राम था जिसके साथ जो आप किताबों में भी आपके मुश्किल सा नाम है, उसका क्या नाम है, रोमेथैम्पथेन के पता नहीं क्या. Yes. So you can correlate it with that. और इसमें quantitation has a role. ठीक है जी. अच्छा, ये भी एक interesting question है. A 55 years old farmer went to his GP with complaints of tiredness, easy fatigability, slurred speech, and recurrent episodes of pain abdomen for the past 2 years. ठीक है. He had been on some Ayurvedic herbs given by a local Hakim for joint pains. Based on the clinical suspicion of physician ने कुछ suspect किया, and then he ordered a few investigations, the results of which are as below. Hemoglobin was 9.2 grams per deciliter, uric acid was 5 raised, 520 micromoles per liter, and urinary alpha minor linolenic acid was 89. Its excretion was increased. What is the most likely done?
लेट टॉक्सिसिटी लिखा जी किसी ने, आप लोग लिखें सारे,
आप लोग लिखें ना,
सब लोग लिखें, उड़ीन में लिख रहा
उसको देख के लिख ले विषय.
हाँ, ये अपना लिखें, they may not be correct.
और इसमें जो लिखेगा मुझे बताएगा कि what makes him reach this.
ये डॉक्टर भाई ने उधर से कॉलेज से.
हाँ जी
डॉक्टर, आपका क्या नाम?
नाम मुझे आता है लेकिन अभी मैं
नो आइडिया. एयरलाइन जब आता है तो आपके ज़हन में क्या आता है सबके? एयरलाइन
क्या आता है? 2 चीजें, वैसे मेरे ज़हन में तो 2 चीजें आती हैं. हाँ, तो दैट्स व्हाई मैंने कोई आधा घंटा लिया इसको पढ़ने में कि why it is not a porphyria. और दूसरी क्या आती है? कॉपर में
नहीं होएगा इसके अंदर,
लेड. अच्छा, ये है जी लेड पॉइजनिंग. ठीक है. Why not AIP, acute intermittent porphyria,
क्यों नहीं है?
क्योंकि मेरा ख्याल था समय से लोग काफी इस पे बहस करेंगे कि why is it not.
तो एक तो हिस्ट्री में आप देख लें, हिस्ट्री भी अच्छी होती है, इम्पोर्टेंट होती है, और
हिस्ट्री इज वेरी इंपॉर्टेंट. हिस्ट्री ठीक है. देखिए HP तो porphyrias में एनीमिया भी होता है ना, तो अब इसमें एक तो ये है कि इट इज एक्चुअली द प्रेजेंटेशन जो basically ALA dehydratase deficiency porphyrias जो होते हैं, they are very rare. Literature में the other day I was reading only 7 to 8 cases are reported. ठीक है, पहली बात. दूसरी, this is not a usual. Though literature में there is a case of a 65-year-old male who presented with this ALA dehydratase deficiency porphyria, right? It is not the usual case of presentation. ठीक है. तीसरी बात जो मैंने इसमें एक हिंट डाली थी, that is raised uric acid. You don't expect to have a raised uric acid in this AIPs. So why the raised uric acid in lead poisoning?
मैम ये करता है ना extraction में है lead competes with that and there is
Not exactly competition. Basically होता है there's general inhibition of all the amino hydrolases. एक तो उसका metabolism effect होता है और दूसरा when lead toxicity it causes toxicity to the tubules, right? So basically ये secondary hyperuricemia है due to decreased secretion. तो डॉक्टर अफशा अनीमिया क्यों है इसमें? लेड पॉइजनिंग में अनीमिया क्यों होता है जी?
chronic lead
poisoning, yes, that's why when it's chronic somewhat near to that.
ये डॉक्टर साहब इनसे ये पूछिए, ये जो ALA इसमें आ रहा है
जी जी
ये कौन सा है? What are the two types of ALA? नहीं वो तो है, वो तो उसके फॉर्म है ना, ALA1 ALA2 होते हैं ना दो, तो ये कौन सा है ALA जो इसमें आता है और जो पॉफारिया में आता है वो कौन सा? ALA हाँ लिवर वाला, चलो ये बता दो 1 2 को छोड़ो, लिवर वाला होगा या आरबीसी वाला होगा? ये आरबीसी वाला होता है। तो ये बेसिकली ये आरबीसी वाले जो है ये उसको इनहिबिट करता है, दैट्स व्हाई इट ऑल द हेमेटोलॉजिकल फाइंडिंग्स जो आपको मिलती है।
और इसमें hemoglobin low state because ferrochelatase is an enzyme which gets inhibited by this lead. This is required for the incorporation of iron into the bone marrow, especially in the ferrous form, which is the more actively absorbable form. And you know, another interesting thing, sir, it is a form of porphyria. It's called plumboporphyria. This condition is also known as plumbo.
because abdominal pain वगैरह होती है,
right?
ये उसको भी inhibit करता है, ALA2 को भी करता है।
और primary ALAD, this is basically secondary ALA dehydratase deficiency. इन दोनों में फर्क ये है कि जो porphyrias हैं, that is AIPs, that is a primary cause of ALAD dehydratase deficiency, and this is a secondary cause of ALAD deficiency, right? So ये मैंने एक लफ्ज यूज किया था आयुर्वेदिक ट्रेडिशनल रेमेडीज में, जस्ट ये क्या मतलब है इसका? बेसिकली ये कहाँ से आया है?
Indian
Yes.
herbal medicine.
ओल्ड इंडियन सबकॉन्टिनेंट्स की मेडिसिन है, ठीक है. दिस इज बेसिकली ये जो ट्रेडिशनल रेमेडीज होती हैं, दे माइट बी यूजफुल इन सम ऑफ द केसेस, बट दे हैव इनका नुकसान ये है कि दे हैव अ पोटेंशियल ऑफ हेवी मेटल टॉक्सिसिटी एंड न्यूमरस रिपोर्ट्स ऑफ अदर मेटल्स, नॉट ओनली लेड, मर्करी, थेलियम, आर्सेनिक पॉइजनिंग, Chinese and Ayurvedic remedies दोनों से आई है. And the other day I was reading कि 40% of more than 6,000 medicines in Ayurveda जो prescribe करते हैं, they contain at least one heavy metal. So you have to, administer them really carefully. And since they are used more commonly for chronic disorders, so there is a greater risk of heavy metal accumulation.
तो हल्दी होती है हर एक में, वो है ना हल्दी का
But that's not उसमें, as far as it is pure, that doesn't make a difference. लेकिन अब अगर इसमें impurities है तो उसकी वजह से. Okay, lead poisoning, acute lead poisoning is relatively uncommon. Most of the symptomatic cases they result from chronic ingestion. ये मैंने साथ क्या लिखा हुआ है? का ये क्या होता है? CNN. बच्चे जो, और ज्यादातर कौन से बच्चे खाते हैं? डेफिशिएंसी वाले, ये पेंट्स और पट्टी ये जो खाते हैं. So it is very important, खासतौर पे ये पेंट वगैरह जो खाएंगे. Inhalation of lead fumes like occupational exposure and use of lead containing traditional medicines जो मैं अभी बताऊंगी, ठीक है. और many of the signs and symptoms of lead poisoning are relatively long. ये मैंने highlight किया है because this is where the lab has to play a role. आप कभी भी you can suspect a case of lead poisoning, लेकिन कभी भी आप उसको confirm नहीं करते unless and until you get the blood levels done. So lab investigations, they play an essential part in the diagnosis and management of lead poisoning.
अगर lead level ना available हो आपके पास, फिर अच्छा sorry.
ये वो जो सर आपसे क्वेश्चन पूछने लगे थे उसका ये जवाब है. इनके भी 2-3 डायरेक्ट और इनडायरेक्ट पैरामीटर्स हैं. जो इनडायरेक्ट पैरामीटर हैं that is erythrocyte zinc, because what happens is that instead of iron, zinc gets incorporated in that protoporphyrin ring, making it ineffective. So erythrocyte zinc protoporphyrin levels are increased. Urinary ALA हमने अभी discuss कर लिया. Now blood lead levels are the single most important measures of direct lead exposure, right? लेकिन अभी recently ये देखा गया है कि जो occupational workers होते हैं वो तो continuously exposed होते हैं ना lead से. So a level rises, a stage rises where the lead levels, they attain a plateau. So lead mobilization tests, right? वो readily mobilizable toxic pools of lead को detect करता है. When we administer this diamocaptosuccinic acid, it's just like वो जो हम I'm forgetting the name, ये कॉपर के लिए कहते हैं ना पेंसिलिन चैलेंज टेस्ट जो देते हैं, ये उसी की तरह का ये बेसिकली कीलेटर देते हैं आप, लेड चीलेटर और कीलेटर, जो कि इसको बाइंड करके जो टॉक्सिकोलॉजिकली एक्टिव पोर्शन ऑफ द लेड है उसको यूरिन में लेके आ जाता है. पेंसिलिन चैलेंज टेस्ट की तरह का ना.
तो चले ये आपको नोट करना चाहिए.
So it is specifically said that this test has a role to play in assessing exposure in occupational health workers. Not in हर बंदे में आप नहीं कर सकते. In case of chronic poisoning में you don't need to have with this, right?
ये बैटरी वर्कर वाला जो
उसमें किया जा सकता है बिल्कुल, क्योंकि उस केस में फिर ब्लड लेवल से अच्छा ही कहते हैं कि ये टेस्ट है. Okay, the last question. A 23-year-old male has presented in the emergency with drowsiness, photophobia, blurred vision, and painful eye movements. On examination, he is disoriented and has a rapid pulse. His arterial blood gases shows metabolic acidosis and a raised anion gap. The clinician is suspecting acute intoxication. Which one of the following is the most likely agent involved? A. Okay. Somebody has said
Why not?
D. Why? Paracetamol?
Paracetamol.
We don't usually have a metabolic acidosis with the raised anion.
जरा सिनेरियो गौर से पढ़े ना.
सिनेरियो कुछ गौर से पढ़े, पहली दो लाइनें गौर से पढ़े. I thought ये तो बड़ा आसान होगा.
Actually ये लोग गौर से नहीं पढ़ा.
टॉक्सिकोलॉजी में यूज कर रहे हैं.
किसी ने डी भी वैसे कहा है. जी डॉक्टर शाह is saying C. Why? Benzodiazepines. Name a few benzodiazepines which cause high anion gap metabolic acidosis. मुझे नहीं पता. सारा देखिए.
सीनियर्स बताएं.
ड्रग्स कौन सी हैं?
अब आंसर करो ना इसका.
ये नहीं है, मैं पूरा पढ़ा हूँ, इसमें से आप अपना आंसर.
चलिए इस पे सर अभी हमारे पास टाइम है तो हम इस पे टाइम लगा.
चलो ठीक है.
तो इस पे जरा गौर करें अभी.
सब ये किसने कोई आंसर नौरीन ने
किसी ने यहाँ से मुझे वैसे आंसर नहीं दिया डॉक्टर अमरीन. इथेनॉल. ओके, व्हाट मेक्स यू से इथेनॉल?
इथेनॉल का है ना.
इथेनॉल, यस.
व्हाई नॉट मिथेनॉल?
व्हाई
इन
नॉट?
दोनों में से है कौन सा?
चलो हाँ, ए और बी. ए और बी.
जो है ना फोटोफोबिया जो है.
Yes, very good, very good. Zabardast Mubin has come
इनका
up
brain चलने
with an
लगा.
excellent answer. ये चैटिंग में मुझे कोई आंसर्स रिसीव नहीं हो रहे सर. मुझे लगता है कि वो
सर रिसेंटली जो मिस्टर के ऊपर वो हुआ
अभी ये इतना इम्पोर्टेंट है.
The answer is D.
क्लिनिकली मिथेनॉल पॉइजनिंग
is very important.
वो हर किस्म पे ये वाकयात होते हैं. आई एम सॉरी मैं इसका नाम ले रहा हूँ, लेकिन वो इसलिए कि वो सेलिब्रेशन फेस्टिवल्स होते हैं और लोग वो इथेनॉल जरा कॉस्टली होती है, वो मिलती नहीं है, तो वो मिथेनॉल पी लेते हैं जो आम स्पिरिट होती है ना. और बल्कि सुना है उसने तो आफ्टर शेव.
जी सर, आफ्टर शेव
पिला दिया जो मुल्तान में कहाँ हुई थी. टोबाटेक्सिन. जी डेथ 42 डेथ्स हुई हैं. ठीक है. बट द फर्स्ट सिम्पटम इज ब्लाइंडनेस और ब्लरिंग ऑफ विजन. क्यों हो जाती है आगे मैडम बताइए. चलिए.
अच्छा जी, इसमें द आंसर इज डी. ओके, इसमें होता क्या है जी मैं बताती हूँ. इट्स बेसिकली अ कॉन्स्टिट्यूएंट ऑफ एंटीफ्रीज, जैसे कि मैंने पहले भी कहा था, विंडो क्लीनिंग फ्लूइड्स एंड कैन फ्लूइड्स. और इसकी पॉइजनिंग कैसे होती है? इट मे बी यूज्ड इंटेंशनली एज एन इथेनॉल सब्स्टिट्यूट, व्हिच इज अ मोर कॉमन सिनेरियो, राइट? Or accidentally as the contaminant in illegal whiskey. Both of them are rather very common. इट इज पहले तो ये देखते हैं कि जी इसमें मेटाबॉलिक एसिडोसिस क्यों होती है. इसमें ये है कि इट इज मेटाबोलाइज्ड इन द लिवर टू फॉर्म फॉर्मिक एसिड which causes severe acidosis. So जैसे कि मैंने पहले बताया कि it is due to the metabolites and not the actual compound which causes metabolic acidosis. Optic neuropathy इसलिए होती है because ये जो optic nerve का retrolamellar portion और Mueller cells होते हैं, actually it is the metabolites which are toxic to them. Formic acid is very toxic to the Mueller cells and the retrolamellar portion of the optic nerve. So it leads to optic neuropathy, right? And due to that, the patient starts having photophobia and altered sensations in the eye, and eventually leads to blindness and death. So this is very toxic. Acha ji. Administration of ethanol or fomepizole to inhibit, this is very, very important. ठीक है? अभी हम ये मुझे कौन बताएगा, डॉक्टर सीमी आप बताएंगी कि हम इसमें इथेनॉल क्यों देते हैं. एक पेशेंट है वो आगे ऑलरेडी मिथेनॉल पॉइजनिंग के साथ आया है. Why are we administering ethanol to him
क्योंकि उसके
as an antidote?
उसको बाइट करनी चाहिए ताकि उसको उसकी मेटाबॉलाइट्स वो
Yes, Azuba is somewhat right. कौन सा एंजाइम? अल्कोहल डिहाइड्रोजनेज होता है. बेसिकली दिस जो इन हर एक की अल्कोहल के मेटाबॉलिज्म में 2 स्टेप्स होते हैं. जो फर्स्ट स्टेप है उसमें अल्कोहल डिहाइड्रोजनेज एक्ट करता है. दैट इज नॉन स्पेसिफिक एंजाइम. ठीक, जो अल्कोहल डिहाइड्रोजनेज की एफिनिटी है इट इज 20 to 40 times greater for ethanol as compared to methanol, so that gets preferentially metabolized. Ethanol gets preferentially metabolized as compared to methanol. और जो इसकी projects होती है they are not as toxic, they get excreted by the kidneys, right? अब इसमें मेरा एक बड़ा इंपॉर्टेंट सवाल है, इसका जवाब मुझे कौन देगा कि जब आपने इसका ऑस्मोलर गैप करना होता है तो डू यू डू इट before administrating ethanol or after administrating the antidote? What is the ideal time of taking a sample in a suspected case of methanol poisoning for osmolar gap? Is it before administration and why? After? Why? या आफ्टर है या बिफोर आंसर है.
What's the answer? बोले?
बिफोर.
Critical thinking.
चलो ठीक है, बिफोर. Why? Yes, because why do you want to the ethanol to contribute its share of the right? We don't want a falsely elevated osmolar gap. ठीक है?
ये आपकी नहीं है.
अच्छा. Okay. The other thing is that sodium bicarbonate therapy for metabolic acidosis आप देते हैं. किसी वक्त
Sorry, don't do ethanol. Don't give ethanol in our setup. क्योंकि वो हो सकता है वो भी contaminated मिले.
उसमें ये है कि usually fomepizole ही administer करते हैं. That is also, but mostly IV form में होता है, but it is expensive. But it is expensive. ठीक है?
So कहते हैं ना, don't attempt it at home.
Indications for hemodialysis is there are few, जिस तरह salicylate poisoning की अपनी indications है, उस तरह की indications हैं. If the expected dose of more than 30 ml has been ingested, the methanol levels are greater than. So for this case, quantitation is very important, right? हमें qualitative results पे rely नहीं करना, we have to quantitate it because methanol levels more than 20 milligram per deciliter, they warrant administration hemodialysis rather than administration of antidote. ठीक है? Observation of visual complications, and when there is no improvement in acidosis despite repeated sodium bicarbonate infusions. And what is the role of lab testing in methanol poisoning? पहले तो ये जो मैंने आपको बताया कि metabolic acidosis होती है due to the formation of these toxic metabolites, and then there is a raised osmolar gap, right? और ये मैंने लिख दिया इसमें कि it has to be measured by freezing point depression. Dr. Ashok, vapor pressure जो depression है osmometer उससे आप measure कर सकते हैं? एक suspected case of methanol poisoning में vapor pressure depression osmometer से, मैंने कहा ना freezing points आप करें, तो vapor pressure से कर सकते हैं आप measure? ठीक, क्यों? दोनों osmometer, बात आपकी बिल्कुल ठीक है, but since this is volatile, तो vapor pressure osmometer से normal and iron gap आ जाएगा, so the results would be discrepant. So you have to, in a suspected case of volatile poisoning, you have to measure the osmolality by freezing point depression. if you actually have to demonstrate the raised osmolar gap. Okay? Then headspace chromatography is the instrument of choice for detection of methanol. And another important thing जो कि हम बिल्कुल भूल जाते हैं, अगर तो ethanol इसको दी जाए, तो laboratory का एक और role भी है, that is monitoring of these ethanol levels to